Hello, everyone. Hope you're all having a good day so far. Welcome to episode 14. Today is Wednesday, December 9th, 2020. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Did you need more information on how to create an effective hospice plan of care? Well, look no more. I get into it in this episode. This episode also highlights the OIG Work Plan for November 2020. I deliver my trusty tips on how to promote quality of care in your care planning in the hospice setting. And I also share a profound note from Japanese art historian and scholar Kakuzo Okakura. If you've checked me out on LinkedIn, you know I'm all about compliance and protecting our physicians and valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organizations, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost the quality of documentation capture and improve coding accuracy as you help your providers paint the medical picture. If you like what you're hearing, go ahead and hit that subscribe button now so you don't miss an episode. Please write in a review and rating on Apple Podcast or wherever you listen to my podcast. I'd really love your support. Now, a quick disclaimer. Before I get started on the episode, this podcast episode and Nexsen Pruet podcast series do not constitute legal advice, but I am fortunate to work with sound healthcare attorneys at Nexsen Pruet. And as their consultant, I have over 10 years of experience in front office, back end, coding, and billing for multi-specialty physicians, compliance, and auditing for both E&M and surgical operative reports. Again, the opinions and insights throughout are mine alone, and they in no means constitute legal advice. So, let's get into Newsworthy. I wanted to go over the 4 new November 2020 updates made to the OIG Work Plan. The first update is titled CMS Oversight of the 2 Midnight Rule for Inpatient Admissions. Now, prior OIG audits identified millions of dollars in overpayments for inpatient claims with short lengths of stay. Instead of billing the stays as inpatient claims, they should have been billed as outpatient claims, which usually results in a lower payment. To reduce inpatient admission errors, CMS implemented the 2 Midnight Rule in fiscal year 2014. Under the 2 Midnight Rule, CMS generally considers it inappropriate to receive payment under the Inpatient Prospective Payment System, the IPPS, for stays not expected to span at least 2 midnights. The only procedures excluded from the rule were newly initiated mechanical ventilation and any procedures appearing on the inpatient-only list. Revisions were made to the 2 Midnight Rule after its implementation. The OIG plans to audit hospital inpatient claims after the implementation of and revisions to the 2 Midnight Rule to determine whether inpatient claims with short lengths of stay were incorrectly billed as inpatient and should have been billed as outpatient or outpatient with observation claims. They also plan to review policies and procedures for enforcing the 2 Midnight Rule at the administrative level and contractor level. While the OIG has previously stated that they would not audit short stays after October 1st, 2013, this actually serves as your official notification that the OIG will in fact begin auditing short stay claims again, and when appropriate, recommend overpayment collections. The final report is expected in fiscal year 2021. Now, the second update to the OIG Work Plan is titled Medicare Part D Compounded Drugs. In 2016, the OIG called attention to significant growth in spending for compounded drugs. Specifically, OIG found that Medicare Part D spending for compounded topical drugs grew by 625% during the years of 2006 through 2015. The OIG has been involved in an increasing number of fraud investigations related to compounded drugs. They will conduct a risk assessment of CMS's oversight of pharmacies compounding drugs for beneficiaries to determine whether systemic vulnerabilities affecting the integrity of Medicare Part D exist. And specifically, they will assess the risk that pharmacies did not meet federal and state requirements. The final report is expected in fiscal year 2022. The third update to the OIG Work Plan for November 2020 is titled Medicaid and ACA Enrollment Processes During the COVID-19 Pandemic. Now, economic and health impacts caused by the COVID-19 pandemic have left our states facing increases in new applications for health insurance through the Medicaid and ACA marketplace programs. Responding to the pandemic, including meeting the new enrollment and oversight demands, has taxed our state healthcare systems. This evaluation will assess efforts by the states and CMS to effectively enroll residents impacted by the COVID-19 pandemic in Medicaid and ACA marketplace plans. By identifying effective practices or any breakdowns in enrollment and oversight systems, this review would help to improve the efficiency of state health insurance enrollment processes under both emergency and more typical conditions. The final report is expected in fiscal year 2022. Now, the fourth and final update for the OIG Work Plan in November 2020 is titled Nursing Homes Compliance with Facility-Initiated Discharge Requirements. A facility-initiated transfer or discharge of a residence from a nursing home can be an unsafe and traumatic experience for the resident and his or her family. So, to address these concerns, Congress passed the Nursing Home Reform Act of 1987 to protect residents against inappropriate facility-initiated transfer and discharge. However, data from the National Ombudsman Reporting System show that from 2011 through 2016, the Long-Term Care Ombudsman Program, established to advocate for older Americans by the Older Americans Act of 1965, cited complaints related to, quote, discharge and or eviction, end quote, more frequently than any other concern. In addition, the media has highlighted the rise in nursing home evictions. The OIG has ongoing work determining the extent to which state long-term care ombudsmen, state survey agencies, and CMS address facility-initiated discharges from nursing homes. To complement this ongoing work, they will examine the extent to which nursing homes meet CMS requirements for facility-initiated discharges. This final report is also expected in fiscal year 2022. Now, in my opinion, I always have providers who need this critical information to review their coding and billing practices or their overarching compliance programs. I think these reports with findings are always most interesting and most informative, and I look forward to analyzing them in the new years ahead. It's also very important for my listeners to keep an eye on these monthly OIG Work Plan updates to see how they may impact you, your provider, or your health system. Remember, stay tuned for my monthly OIG Work Plan updates. They drop the second Wednesday of each month. And now, it's time for my best practice tips in Trusty Tip. So let's dive into proactive compliance in the hospice setting. Remember, the primary goal of hospice care is to meet the holistic needs of an individual and his or her caregiver, family, for whom curative care is no longer the preferred option. To support this goal, the hospice provider develops an individualized plan of care, the POC, established by an interdisciplinary group, the IDG, and is overseen by a registered nurse coordinator, an RN. All hospice care and services offered to hospice patients and their families must follow an individualized and written plan of care. It's the hospice IDG that creates the POC in collaboration with the attending physician, if there is any, the patient or the representative, and the primary caregiver in accordance with the patient's needs. The POC should also reflect patient and family goals and interventions based on the problems identified in the initial, comprehensive, and updated comprehensive assessments. The POC must include all services necessary for the palliation and management of the terminal illness and related conditions of the individual. The hospice POC should link with the needs identified in the initial comprehensive assessment. Hospices may identify needs in the comprehensive assessment that are not related to the terminal illness and related conditions. The assessment should document that the hospice is aware of these needs and, if warranted, note who is addressing them. And remember, I discussed the use of correct appendages of hospice modifiers in this very matter in episode 10. Now, the hospice must ensure that each patient and the primary caregiver get education and training as appropriate to their responsibilities for the care and services identified in the plan of care. So, some principles of care planning that Medicare requires in promoting quality of care includes, number 1, interventions to manage pain and symptoms. Number 2, a detailed statement of the scope and frequency of services necessary to meet the specific patient and family needs. Number 3, measurable outcomes anticipated from implementing and coordinating the POC. Number 4, drugs and treatments necessary to meet the needs of the patient. Number 5, medical supplies and appliances necessary to meet the needs of the patient. And number 6, the IDG documentation of the patient's or their representative's level of understanding, involvement, and agreement with the POC in accordance with the hospice's own policies in the clinical record. Now, care coordination is also fundamental in the hospice setting. The IDG works as a coordinated team to optimize comfort and dignity according to the patient's and family's needs and goals of care. The IDG must include, at a minimum, the professions of nursing, medicine, social work, and pastoral or other spiritual counselors. Additional team members may include representatives from other therapeutic services, for example, physical therapy and music therapy and art therapy, as well as other care and supportive personnel such as hospice aides and volunteers. Additionally, hospices are encouraged to include the patient's primary caregiver as a participant in the IDG. So, the IDG is positioned, therefore, to support and manage the physical, medical, psychosocial, emotional, and spiritual needs of hospice patients and their families through an individualized plan of care. The IDG establishes the POC at the time an individual elects hospice and continuously updates the POC while the patient gets the hospice benefit. Additionally, the hospice must offer a bereavement plan of care and supportive services to the caregiver and family for 1 year after the death of the hospice patient to further support the bereaved family. But of course, CMS has analyzed a 2019 hospice survey with data and found deficiencies at the condition of participation for interdisciplinary group, care planning, and coordination of services, which are found in 42 CFR 418.56. Common survey deficiencies were related to plan of care implementation. For example, CMS found that number 1, POCs were not individualized. Number 2, they found that hospice staff missed direct care visits. Number 3, they also found that documentation of visits did not meet requirements, for example, in wound care. Number 4, they also identified deficiencies where plans of care were incomplete. For example, they were not inclusive of all needed services. And finally, in number 5, they found that IDG meetings were inconsistent, with POCs not being updated. So a huge help to avoid these types of survey deficiencies is to have an RN coordinator, which is why CMS requires that the hospice agency designate an RN who may be identified as the RN coordinator, who serves as a member of the IDG and is responsible for coordinating the implementation of the POC. This person may also be responsible for offering direct nursing care to the patient and easing collaboration within the IDG for service delivery. CMS recognizes this role as vital to ensuring that quality care is appropriately coordinated and delivered in a timely and meaningful manner. The RN coordinator ensures the POC remains updated, individualized, and relevant to the needs of the patient and family by number 1, ensuring the continuous assessment of each patient's and family's needs. Number 2, documenting and revising patient care goals and objectives in a timely manner under IDG direction. Number 3, communicating with the IDG any changes in the delivery of services from the established POC. Number 4, easing the exchange of information among IDG staff and the patient and caregiver. And number 5, working with other members of the IDG to ease the inclusion of additional services when indicated. Number 6, developing and revising patient care goals and objectives in coordination with other members of the IDG. Number 7, monitoring for successful implementation of the POC. And number 8, implementation is the beginning of ongoing management for compliance with the hospice's conditions of participation, in addition to patient and family goals. So remember, as you strive to develop proactive compliance for your hospice setting, remember that all hospice care and services offered to hospice patients and their families must follow an individualized and written plan of care. That plan of care should reflect patient and family goals and interventions based on the problems identified in the initial, comprehensive, and updated comprehensive assessments. The RN coordinator can ensure the POC remains updated, individualized, and relevant to the needs of the patient and family. The POCs must document any deviations to the services offered, which means that hospices must update POCs based on the needs of the individual or those the IDG identifies. So, by understanding the multifaceted details of hospice care planning, as well as all of the medical documentation necessary and required in this setting, this helps paint a clear, well-defined picture for a certified medical coder to abstract codes with accuracy. And finally, this week's inspiring quote in Spark is from the Japanese art historian and scholar Kakuzo Okakura. The art of life is a constant readjustment to our surroundings. Now, although Okakura wrote this in his Book of Tea, I believe this captures exactly what we as a humanity are going through right now, 100-fold. I think we continue to readjust to our surroundings in both home at work, and in this space of healthcare. We are all keenly aware of the mighty impacts COVID-19 has had on all of our lives, the lives of our friends and family, and we continue to educate ourselves on its daily status. What's going on everywhere so we can constantly readjust. I am happy Kakuzo Okakura's spark still burns brightly in all of us today. So, that wraps up today's episode. Please go out and make this a great day, an incredible week for yourselves. Aim a little higher, do a little more, and give back in any way you can. I appreciate you diving into today with me. And if you would like to inquire about my consultant services, you can always reach me through my email address at nexsenpruet.com. I'll leave links to everything in the show notes below. Please continue staying safe and healthy. Practice safety for one and all during our collective life in the time of coronavirus. Thank you for listening in on today's episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday. If you want more information from me, go ahead and follow me on LinkedIn or send me an email at sonalpatel@nexsenpruet.com for all my consulting services in medical coding, auditing, and compliance. Thank you.